So the beauty of where we are today in terms of the management of metastatic castration-resistant prostate cancer is that since 2010, we've had a number of agents that have been approved by the FDA for these patients. And again, I want to stress the fact that metastatic castration-resistant prostate cancer are people that have already been treated, have experienced a biochemical failure, a rise in their PSA, have been placed on androgen deprivation therapy, usually leuprolide. Despite that, their PSAs are going up and their testosterone levels are low. In the past, we have usually called those patients what we call androgen insensitive, hormone resistant, hormone refractory. We've changed that nomenclature to this concept of castration resistance because we know at a molecular level, the androgen receptor still plays a very active role. We know prostate cancer, we discovered this in the 40s. Huggins and Hodges, urologists, discovered that prostate cancer is driven by the male hormone testosterone. So the mainstay of prostate cancer, once it advances, has always been depletion of testosterone. And you can wipe out its production, or you can block the testosterone to its binding, to its chair, if you will, within the prostate cell at the receptor. So again, the original concept was, once these patients starts to fail androgen deprivation therapy, castration, it was felt that the cells were no longer responsive and that the cells had actually picked up different mechanisms of growing. However, what we know now is that the androgen receptor, the majority of the time, still stays very active, and the prostate cell, through a series of mutations, has figured out ways to continue to grow despite the low levels of testosterone. So, yes, the patient has a low level of testosterone, however, the androgen receptor has figured out a way, the cells have figured out a way through the androgen receptor to stay sensitive. One of the proposed mutations is that the tumor cells itself will actually start to produce its own hormone. So, the analogy would be if you had a car, it would make its own gas. These tumor cells can potentially make their own hormone. So one of the approved therapies since 2010 has been a newer, what we call androgen synthesis inhibitor, and that's abiraterone acetate or Zytiga. So the beauty about abiraterone acetate, it will continue to knock out production in the testicle, which is happening anyway, because these patients still need to be maintained on androgen deprivation therapy. It will knock out hormone production in extragonadal sites, usually the adrenal gland, but it can also knock out production at the tumor cell itself. So that's how abiraterone acetate works. We had other drugs that did something very similar, and it was ketoconazole. This seems to be just more potent. The other drug, one of the other agents since 2010 that has been approved, is what we call an androgen receptor signaling inhibitor, or an anti-androgen. So we know there are a number of first-generation anti-androgens that have always been available, and we've used them in various stages of prostate cancer. Those would be bicalutamide, flutamide, or nilutamide. So what happens there is that these drugs, they don't knock out the production of the hormone. They actually sit on the androgen receptor so that the testosterone, whatever's left, cannot sit down. Think of it almost as musical chairs. It's preventing the testosterone to binding to its receptor, which is what starts the whole cascade. So the problem there in these older agents is that the cells get smart and they will actually start to produce more receptor. So the newer agent that was approved in 2012 is enzalutamide, or the trade name is Xtandi. So this is a newer, what we call second generation androgen receptor signaling inhibitor, and it will competitively bind on the androgen receptor. But the beauty about it is that it's much more powerful. But the beauty about it, with all the studies now, since it got approved, it has a survival benefit. Whereas the older agents, bicalutamide, nilutamide, and flutamide, did not have a survival benefit. We actually now have reported on a couple studies in head-to-head trials looking at bicalutamide versus enzalutamide, and enzalutamide is a superior agent. So I think it's important to remember that if your doctor recommends that you get on enzalutamide, and it sounds familiar because you've been on bicalutamide in the past, it's a much more powerful agent, and in head-to-head studies, it's very superior.